Thank you, Hannah. I will now call this meeting to order, August 23rd at 10 a.m. Can everyone online hear us okay? Perfect, good. And Chris Peabody won't be joining us. He's trying to get into a dentist this morning. Hannah, if you would do roll call, please.
Thank you, Madam Chair. Sue Carlton,
Present.
Luke Charbonneau,
Here.
Brian Mill,
Present.
Kevin Eccles,
Counted for.
Chris Peabody, Chris Peabody, Chris Peabody, Sue Patterson,
Present.
Helen Claire Tingley,
Good morning, everyone.
Kenneth Craig,
Present.
Nick Saunders,
Morning.
Chad Richards,
Present.
and Beverly Wilkins.
Present.
Thank you.
Thank you. Item 3 on the agenda is amendments or additions to the agenda. There is one item to be added by Dr. Era about MPOX. So I could have a mover and seconder for the agenda to be approved by the Board of Health as amended. Luke and Beth. All in favor? That is carried. Disclosure of pecuniary interest, you may declare one at any time if one should arrive throughout the meeting. Adoption of the minutes for Friday, July 26, 2024, and Wednesday, July 31st, 2024, Executive Committee meeting. The recommendation is that the minutes be approved by the Board of Health as presented. Could I have a mover and a seconder, please? Luke and Ken. And is there any discussion? Seeing none, I will call the vote. All in favor? And that is carried. Moving on to correspondence and media releases, item 7.1.1, the letter of support from Middlesex London Board of Health. Dr. Era?
Thank you, Madam Chair. So we have two pieces of correspondence. The first one is a letter from Middlesex London to the Prime Minister of Canada, and it's related to basic income guarantee. And the recommendation is to receive, since the board has already participated and was quite supportive of the initiative on the provincial level. The second correspondence is from Rainfield County District Health Unit. It's a letter to the Premier of Ontario and the Minister of Health Deputy Premier, and it's related to request to continue funding of water surveillance related to the COVID pandemic and the MCC, which is a modernized case and contact management software. The recommendation is to receive and elaborate more.
Well, thank you. Does anyone have any questions about either of those letters? Seeing none, we will move on to media releases. And Vinny, I think you're on here with us.
Yes, thank you, Madam Chair, and through you. There are 10 media releases in today's agenda package. 4 relate to a pair of beach postings that were issued in July and August by Grey Bruce Public Health in consultation with the respective municipalities after beach water samples confirmed E. coli levels above Ministry of Health standards for safe swimming and bathing. Public Health issued a media release July 19th to inform the public about a beach posting and swim advisory for Kelso Beach at Nawash Park in Owen Sound. A subsequent release was issued July 25th to announce that the beach posting had been lifted. And on August 2nd, Public Health issued a media release to advise the public that a beach posting and swim advisory had been issued for the Southampton Beach. A subsequent media release was issued August 9th to announce the beach posting had ended due to favorable sample results. A media release was issued July 25th after a bat from Grey Bruce tested positive for rabies. The release advised people to remain vigilant about the risk of rabies and included steps on how to protect against acquiring the virus. Public Health issued a media release August 15th about an increase in pertussis cases locally and in provincially and in Grey Bruce. The release reminded residents that staying up to date on routine vaccinations is the best defense against the highly contagious respiratory infection. And Public Health also issued media releases on July 22nd and August 15th related to animal exposure investigations, and on August 1st and August 7th in response to a series of opioid poisonings in Grey Bruce. And that concludes the media releases for this meeting.
Thank you, Denise. Are there any questions or comments from any members of the board? Helen Claire?
Thank you, Madam Chair. Through you to Denis, just or to Dr. R, I guess, wondering what is behind the uptick in pertussis. If memory serves me, those initial vaccinations, DPPT, and one of those P's stood for pertussis, were given to newborns at 2 months, 4 months, 6 months, and then boosters every 10 years. What's going on? Why are we suddenly seeing this? Thank you.
Through you, Madam Chair, there's no specific reason why we're seeing this. It just we look at the data where the cases are in the susceptible population so early on in children born in the first 6 months, the baby would have immunity from the mother, and after that, there is higher incidence of the disease. So if we provide vaccine to that group, that's going to be protective. The other groups on the list of vulnerability would be the older individuals, and there is limited resources in the province or in the system to tackle all groups at the same time. So, to my understanding, at this time we move to the next vulnerable, and it is the older group. I'm not aware of the changes in the data on the sorry. I'm not aware of changes in the data and the efficacy of the vaccine or the type of the virus itself affecting the population.
Does that
Thank
answer your question, Helen Claire?
Thank you, Madam Chair.
Okay. And Bev, you have come to done. Okay. Luke.
Thank you, Madam Chair. And just a quick question to Dr. Era about the beach testing and those results that we received. Obviously, it impacted my community, but it happens every now and again in different communities. And I was wondering, it's a bit of a lagging indicator, right? We do the tests every Wednesday, I think, and then we get the results back on a Friday. And then we don't test again until Wednesday. I understand why that is. It's just a practical matter in terms of collecting the samples and getting them to the testing facility and then getting the results back. But I wonder, and I put this out there because it's a thing I heard a lot when these most recent postings were made. Is there any possibility or any mechanism, Dr. Era, for us, or maybe for a municipality, to accelerate the retesting, because it's a major impact, obviously, to a community economically to have its beaches closed over any weekend in the summer. And I understand public health only has so many resources to do testing, but is there a way when a negative result comes back for perhaps a municipality working with public health to do the retesting on an accelerated basis to try to get that answer back that the beaches are safe more quickly than on a standard schedule? Interested to hear your thoughts on that.
We can definitely, and we do reach out to the lab to see if there is any way we can do expedited results. It's multifactorial, like it always is. When there is a rain, there is increased in potential contamination of the water. Then you need a number of days for that to clear. Repeating the test overnight is only gonna probably produce the same result. And if it is a result that is negative, can we trust that it is negative overnight? So again, there's a practical and technical aspect to it. And in certain scenarios, we take samples in more in the chemical contamination. We take samples throughout the week and we store them and we test the next week one. And if it is negative, that's great. If it is positive, we can go back and see the other ones. Obviously, that's not for bacteria, it doesn't hold, but there are many layers to it that when we connect with the lab to request expedited testing, there are technical barriers to earlier result as well.
So just to be clear through you, Madam Chair, then the answer is, and we're doing it just about as quickly as we can, and the results are coming back as fast as it can practically be done from both a practical and a scientific basis. Am I right to put it that way?
Yes, I would believe so. Yeah, like from our team, yes, from the team of the municipality, work with them with the lab. And again, it's not something we have control over, but my understanding from our colleagues, that's the best I can do.
Very good. Thank you, Madam Chair.
Go ahead.
Just a point of curiosity. When you do the testing through you, here we are. When the testing is done, where is the lab? Here or elsewhere?
Usually is provincial lab, the Public Health Ontario lab, and there is one in London, one in Hamilton, one in Toronto. And there is a mechanism internally to that to direct the sample to the fastest spot where it can be tested.
Okay, because are they still growing it on agar or whatever to see if it's Ebola, those kinds of things, or is it visual that they do testing or chemical? I don't know anymore. I ask of curiosity.
I believe they do both, just depending on what.
So that takes it in room to grow. Okay, good. Thank you.
That's a good point, definitely.
So that therefore it can be confirmed. Yep, okay, thank you.
Thank you, Beth. Any other comments or questions there? Then the recommendation is that the correspondence and media releases be received by the Board of Health for information. I have a mover and a seconder, Sue Patterson and Helen Clare. All in favor? That is carried. So we're moving on to medical officer of health update. First one being the opioid situation in Rivers.
And then share a lot of different updates from last time.
Okay, and the next item, strengthening public health.
It's similar to it, Madam Chair.
8.3, program report for oral.
I believe we have senior manager Chinera with us to present on it.
Good morning, Board. Through you, Madam Chair. I'll be presenting on the Board of Health report for the oral health outcomes. This report is a presentation of the summary of the school-based dental screening surveillance that was done this past school year. During the year, the Grey Bruce Public Health were able to screen students in 100% of the eligible schools during the 2023-2024 school year. We screened 5,874 students, 86% of those eligible. Of those that we screened, we observed that we have been having annually an increase in the number of students screened from 82% in 2021/2022 school year to the 86% we currently have for the 2023-2024 school year. Through this screening, we are able to find students who are eligible for the emergency and essential services stream of the Healthy Smiles Ontario program. And we have observed that this proportion that are identified that will be benefit from the EESS program has been steady for the past 3 years. They've been ranging within 8% and 9%. We continue to plan in the upcoming school year to try and look for ways to increase the proportion of students we are able to screen in the schools, hoping to increase the proportion from 86% to a higher percentage. It is my recommendation that the board will receive this report for information purposes, and with that, I'll be available to any question that board members might have with regards to this report.
Thank you for that. Are there any questions from the board? Ken?
Through you, Madam Chair. Thank you for this report, very informative. My question is the regards the receptivity of the Amish and Mennonite schools regarding the screening. And, I'm delighted to see that. Are there any barriers yet to be overcome to have greater reception, or are they openly receptive to all the medical opportunities the Board of Health or the Public Health provides?
Well, I'll be able to speak to the through you, Madam Chair, to board member. My apologies for that. I'll be able to speak with regards to dental. They've shown they've been quite receptive to the dental program and signing on to be screened for the dental program. Now, other aspects of other programs, we deliver things like immunization, and we do experience some challenges, but we continue to work with them in partnership to try and address those barriers and challenges. That's to say, there are areas we still have work to do.
Okay.
So the follow-up to that is, are those policy areas that the board should address, or are those cultural issues or opportunities? Like, is that a responsibility the board needs to address, or is that more of a operational issue that have we provided the opportunity for the staff to do what we're encouraging them to do, or is what we're doing getting there? That's kind of my question.
Thank you, through you, Madam Chair. A number of those challenges are operational, which is something we do have staff that constantly work on, addressing this, addressing the barriers when they do come up, trying to look at ways to, if there's information that is required, trying to provide them information, trying to address any concerns. So these are things we are doing at the operational level. Granted that we just came through the pandemic, but there's still room for us to grow along this path. So at this moment, we're trying to manage it operationally. If at any time we think it's something we will move to the level of policy, then definitely that's something we'll bring forward to the Board of Health.
Okay.
Thank you. I think that answers the question. Dr. Herron, do you have anything to add to that? Okay, any other questions? Okay. Seeing none, then we will move on to the next report on school health. Vision screening, sorry. Go ahead.
Thank you, through you, Madam Chair, again. I'll be presenting a report on the updates of the in-school vision screening program. As part of our mandate, we are tasked with providing in-school vision screening to all kids in the senior kindergarten classes in Grey Bruce. We do this in-school screening in collaboration with District 9 Lions Club International Volunteers. So the way the partnership works is that we do make the arrangements with the school boards. Then on the day of the screening, volunteers of the Lions Club International who are trained to do the vision screening go to each school and provide the screening. This past year would be the second year we've been able to do this. In the last year, we were able to screen 89%, 1,754 SK students in 47 elementary schools in Grey Bruce. Of those we screened, 38% of them, 669, were identified with vision concerns. And our recommendation is when we do identify those vision concerns, we encourage the parents to ensure to take the kids to an optometrist for a comprehensive screening. Apart from those that were identified, we equally encourage parents as a whole, regardless of what the screening result is, to ensure that they take their children to the optometrist for a comprehensive eye examination, because we make it pretty clear that the screening does not supersede does not supersede a comprehensive eye examination. So we do encourage all parents to do that. But of course, when we identify concerns, we just try and add an increased emphasis for those parents to go see an optometrist. So we've had this partnership for a while, and we've enjoyed the partnership with Lions Club. We enjoyed the cooperation we've gotten from the participating school boards and schools. So based on that, it is my recommendation that the Board of Health receive this information. With that, I'll be available to answer any questions the board may have with regards to this program.
Thank you, Shamir. Are there any questions regarding this report? Luke, go ahead.
Yeah, thank you, Madam Chair. Just more of a comment. I just think the partnership with the Lions is a really great thing. I mean, that's to be able to marshal a volunteer group like that to help us deliver such an important service in the schools is really fantastic. And I just, Madam Chair, I wonder, and apologize, I don't know what we've done to sort of celebrate that partnership in the past, and maybe Dr. Era can fill us in, but I really think a letter from yourself, Madam Chair, and Dr. Era to the organizers and the local Lions Club to thank them for doing that work would be really appropriate. When you have volunteer groups like that, expressing appreciation is always a good thing. So I leave that to you, Madam Chair, but just a suggestion. Thank you.
Thank you. I think that's a good idea. What would normally be a procedure for that? Is that something the Board of Health would do?
Through you, Madam Chair, excellent question, and definitely credit has been given to partners that we work with continuously through our operations, through our emails. I would, if we are going to send one letter to one partner, I would examine first what we are sending to the rest of partners as well. It shouldn't be one case. We work with over 280 partners. So again, probably a senior management item, and we can bring back to the board a question specifically about this and what we have been doing and what we can do also from board level.
And
Through you, Madam Chair, and to my colleague, Councillor Charbonneau, I know that last year when we received a report similar to this, it was my words were at the council table expressing appreciation to the Tiverton and Kincardine Lions Club, and broadly. So we don't have enough members on the Board of Health to do that for every council and grade groups. So I do appreciate the challenges and expressing that, but that expression of appreciation is, as Mayor Charbonneau said, very valuable.
yes. Okay, so we'll leave that with Dr. Era to discuss with the senior management team then. Okay, so if there's no other comments or questions there, the recommendation is that the medical officer of health update be received by the Board of Health for information. But I move her in a second, please.
Helen Claire had her hand up there a second ago.
Oh, I'm sorry. Thank you. Did you have a question, Helen Claire?
Yes, I did. I had understood from Dr. Ara that he was bringing back that there already is something that happens regularly to thank the multiple stakeholders involved with the Board of Health. I'm not really hearing that well. So I just wanted to make sure that what I understood from Dr. Ara is there already is stuff that goes on, and that will be itemized and brought back in a report so that the board can look at it, and that it's important that we as a board don't single out any one particular stakeholder group, that everybody is thanked appropriately. I just wanted to make sure that was what I understood, and I think that it is a good idea if the board sees that there's not regularity with that perhaps the executive have a look and establish something. But I mainly wanted to check that, Dr. Ara, what I was understanding is that already takes place and is on a timeline. So I'm wondering if I could have some clarity with that from Dr. Ara. And I thank my colleague, Mr. Saunders, for acknowledging me. Thank you.
Yes, thank you, both of you, and I apologize for missing your hand up, Dr. Era.
Through you, Madam Chair, I put the microphone right beside me. Sorry if I was mumbling. So I will connect with the ask senior management to look into which programs are dealing with partners and how we recognize them. I know there are multiple mechanisms. They're not usually through the board or on behalf of the board unless there is specific involvement from the board. I can bring the summary back to the board and see how we can also improve the process if possible, or involve the board if there is. It's important to the previous comment was councillors can recognize partners. It's really important for the board to speak through the chair as whole, and not each member to speak on behalf of the board. I know we do it and we have different tabs, but it's just important to have that communication. If it's going out to the partners on behalf of the board, to go through the chair of the board.
Okay, so back to the recommendation, and I didn't get a mover and seconder. I did see Brian's hand up. Who wants to second this? Kevin? And there's no more discussion on it, I will call the vote. All in favor? That is carried. Thank you. Corporate Services Financial Report. Oh, sorry. I'm sorry, I forgot. We had an item there. Go ahead, Dr. Era.
I'm just sharing my screen. We usually send these to the agenda, but the update came from the ministry 2 days ago or 3 days ago after the agenda went out. So this is a report situation update on Mpox, monkeypox virus. And it has, I put it together with 4 points of update, the background, the global trends, including emergency of more severe Mpox strain, current epidemiology in Ontario, prevention and control activities, Public Health Ontario, and prevention and control activities by Red Rose Health Unit. Just in brief summary on the situation, and would help the public listening to us to understand where we're at. So the World Health Organization on August 14th, a week ago, declared public health emergency of international concern due to the emergence of spread of novel and more severe Mpox strain, clade 1B, and that affects a number of countries in one region in Africa, and there was one country outside, which is Sweden, from the report. And anytime that it's not in one region globally, that escalates the severity of it. In general, the virus is not the type that could cause a pandemic. It transmits from person to person, and sometimes through the sheets if there is direct and significant exposure to bed or items that the patient had dealt with. But with minor modification of behavior, usually it's preventable. The current epidemiology in Ontario, you can see from the screen, in 2023, there were 33 cases, and in 2024, there has been 124 so far in the year. So there is some increase. However, the numbers are very small numbers relative to the population we're talking about in millions. The majority of cases are, absolute majority of cases are men who have sex with men. And as the report says, close to 85 of Mpox cases in Ontario are unvaccinated and have only received 1 dose of the vaccine. Public Health Ontario has a number of activities that has been updated in the last couple of weeks as well, including communication about the virus, including laboratory testing, includes working with the ministry, updating the infections prevention control IPAC recommendations. And they support health units throughout cases, especially if the cases are related to a specific age group less than 18 or in women. Most of the cases are in men, or absolutely almost all the cases that are identified. So the health unit continue to do case and contact management to prevent the spread of the disease. We work with the Public Health Ontario, as I mentioned there. In cases less than 18, we ask for more support for guidance, and in females. Clinical services, the same ones that we provide for sexual health and syphilis in the area, we provide the same service for Mpox. Partnership and education with healthcare providers locally and communication to the public. Financially, the application of the situation or the response to it is built within our budget, and strategically it is linked to prevention and control of communicable disease and infectious disease. So all in all, the Mpox virus is an area of focus for Bruce Public Health. We continue to work with the healthcare providers locally, with the partners provincially, and with the public to address this. I included a couple of references, and Public Health Ontario has a really good web page that's updated every 2 weeks on the situation in Ontario. The data in the report is directly from the update. Open to question as always, Madam Chair.
Thank you, Dr. Herr. Are there any questions or comments? I don't think I'm seeing everyone on the screen now. No. Oh, Kevin, go ahead. Kevin?
Thank you. Going through the report there, and you said in Africa it's, predominantly spread heterosexually. And yet in Ontario, we're saying it's in gay men. What's the variance from one continent to the other, I guess? Or is it just a very minor and it just happens to be in Ontario that the spread is started in the gay community?
So the absolute majority of cases are men having sex with men. That's everywhere. No, not just in Africa. The 33 cases last year in Ontario are identified in this group.
Does that answer the question?
But it's predominantly in the heterosexual community, not the homosexual community in Africa, was what the report said. In Congo, you said it was heterosexual, mostly in children.
Right. So it's, sorry, my apologies. I thought you were saying the opposite in Ontario is so no. There are a number of reasons for this. I can't speak to it as an expert because I'm not involved in it. But one of it is the emergence of this new virus that the clade. Clade is a type of virus. It's a cousin to the other clade. The cladistic principles would say that organisms that have similar characteristics are closer as cousins, or if I can use the word cousins. So clade 1B and 2B, one of them is more infectious, so it can spread to close contacts more than the previous one. Plus, I presume, and it's a safe presumption, that the IPAC standards and the countries in Central Africa are different from the IPAC standards here, where if somebody is ill, they can isolate, versus there could be a number of people in the same household using the same interacting with the same items. So mainly those would be the two reasons I can think of. But again, it is predominantly the first one, more or less, because of the significance of the change in the virus. The World Health Organization declared it as a different plate, not just a different variant.
Ken, go
Thank you.
ahead.
If I might, Madam Chair, if I might suggest, for this lay person to explain what Dr. Ayres just said. Many of the pictures we've seen in international newscasts have shown younger children with the Mpox symptoms. And as you explained, Dr. Ayres, like that's through contact. Many children in the family, small children, boys and girls sleep together in the same bed. Perhaps the sheets aren't washed quite as often as they are here. It would suggest to me that that is the reason why there is a more, it's maybe not equitable, but a more distributed cases of Mpox. Is that a probability, a possibility from a lay perspective?
Madam Chair, it is a possibility that that's a different IPAC standard. So I use the word IPAC standard. It is the isolation and interaction with the patient.
Thank you. Smile and nod your head and say, yeah. That's as lay person as you got it. Yeah.
Any other comments? Ellen Claire.
Thank you, Madam Chair. Through you to Dr. Ara, I'm also wondering about the data collection from African nations where perhaps homosexuality is not as acceptable as it is in the West. So wondering if that might actually skew the data where people from the Congo may not be identifying as homosexual. Thank you.
Yeah. Madam Chair, yes, I would see this as a possibility to do. Again, if there are multiple reasons usually for any difference in data, and I don't have the access to that data set or the authority to speak to it too.
Okay, thank you for all of those comments. Is there anything else? Not seeing any. The recommendation here would be that the Board of Health receive that report for information. Over a second. Before we started this one? No. Okay. All in favor then? That is carried. Item 9, financial report. Over to you, please.
For you, Madam Chair, it's the June 2024 financial items. So as of June 30th, we had a surplus of $356,000. Seniors dental still had a surplus of $90,000, which is similar to where it was sitting at the end of May. And our inventories program surplus is now in a position to put $273,000. Seniors dental is going to greenlight our dentist to book some additional OR procedures in the last part of the year to utilize some of that extra funding that we have sitting there. For funding, year to date, our funding is aligned with our budgeted expectations. Our salaries and benefits are under budget by about $14,000. This variance is primarily due to vacancies in a few positions, including that position consultant. For the entire year, we currently have numerous job postings, and recruitment is well underway for a handful of positions. Most operating lines continue to be under budget, notably our professional development, materials and supplies, and IT equipment and software support supplies. And I have been meeting and corresponding with each of the managers to discuss their year-to-date budget utilization and discuss their year-end spending plans to ensure that their budgets are going to be used, or identify budgets that aren't going to use that money so we can possibly allocate it elsewhere. For capital projects, so the Walkerview Clinic is now substantially complete. We are waiting on the occupancy permit, but there's a grand opening event coming up soon, and our clinics are scheduled to start in September.
Thank you. Do we have a date on when the grand opening is going to be? Has that been determined yet?
Madam Chair, I don't know the exact date.
No, not yet. Okay, thank you. Any questions or comments? Okay, seeing none, we will move on to the next item here, which is policy review, the 526 years of service recognition.
Yes, including Madam Chair. We were using this policy for our annual years of service, service event that we have. And we were just hoping to clarify some of the language in there. So under the policy section, the first sentence says calculation for years of service will be from the employee's date of hire was the existing language. And we wanted to update that to say the original date of hire. Employees can have multiple dates on their employee records. So some employees, say during COVID, they may have originally started with us in 2020, worked with us for a couple of years. We didn't have a permanent position for them, and then they came back and joined us later. So we would like to give them credit when we're figuring out their years of service with us based on their original hire dates. We just want to make that clarification in the policy, because we've run into a couple of those scenarios and like, well, which hire date are we basing years of service on? An original hire date would align with the practice that we've had in place. And we also, under the value of service recognition award, it previously said $15 for a metal twist ballpoint pen. We, in some cases, can't always get those pens for $15 engraved, so we just wanted to change the wording to a small appreciation gift. So this year we did engraved keychains for staff. So some kind of small token to acknowledge those that have reached 5 years of service. We just wanted to update that language.
Okay, thank you. Any comments or questions from anyone? Yeah? Yes, go ahead.
Through you, Madam Chair. Thank you for the report. The language issues, that's fine, but I'd like to address the value of service recognitions. And I viewed this in the context of an employee retention policy rather than, you know, you've been here for a long time, here's something for you. And in many respects, the first two items there, they should, like in my estimation, I haven't researched this about industry standards or best practices, but that's what you should get after 3 months, not after 10 years of service, like seriously. And if that's what I got after 10 years, it'd be like, thank you. But I think it would, like from a board perspective, it would take you longer to do the work than the value of the gift. And I'm wondering whether there should be, for me, from my perspective, I front load the service recognition. You haven't been here long, but we want to tell you how much we appreciate you. We want you to stay. We want you to get the 50 years. And I'm not even sure an employee can actually do that. Whether there's mandatory retirement age and there's child labor laws, but anyway, like I'm not sure whether it will be the opinion of the board to have a look at the value of our employees early on in their career and how we retentionize them. So, or whether that is a management education policy. So even if you don't like that employee, like bend over backwards to keep them. Like it's not about whether you like them or not. Are they doing good work within their portfolio? So I leave that open for discussion or not, depending on where the board's at, but it's the value of service recognition award seems not appropriate in today's economy. And also it's not indexed. So I'm not sure how that works. No, seriously, it's like if this was produced 20 years ago, they're great numbers. Today, so I leave that with you, Madam
Thank you,
Chair.
Ken. Helen Claire, go ahead.
Thank you, Madam Chair. Just to point out that the board's single employee is the medical officer of health. So anything to do with employee recognition in terms of amounts, values, is it suitable, does it meet the industry standard and so on, is operational in nature and does not concern us as a board. Thank you, Madam Chair.
Ken?
Excellent point. Dr. Era, after you've been here 10 years, would you like $15 and a small gift. Then does that tell you how much we appreciate you in any way? So even though this is, if that's the case, and I agree with my member, then this is worded incorrectly then, because it should just be, we're talking about the medical officer of health. It would seem to me that as this is presented as guidelines for staff regarding distribution of appreciation gifts on a wider scale, if you could confirm that for me, Madam Chair, I would appreciate that.
Okay, let me first go to Nick.
Thank you, Madam Chair. I'm in agreement with Helen Claret. This is an operational thing. I also feel that it shouldn't be just a one-off when we're recognizing our employees, or the Board of Health, or the health unit is recognizing their employees. I feel as a board that we need to ensure that all employees are welcomed and felt appreciated. And whether it be through once a month a dinner that comes in to nourish their minds and their spirits and their soul, or whether it's, making sure that everybody's taken care of at Christmas or on those special holidays so that nobody is feeling left out or may not have that I've lost my word there. Anyways, making sure that they are taken care of. Support is given to all employees at all times in recognition to employees. And again, I'll go back to Dr. Era here, and that is in recognizing all the tremendous work that he does as a Board of Health, medical officer of health, and to all of us sitting around this table that are currently sitting here. It's the appreciation of sitting with one another and being able to trust one another, to be able to use our words in a good way with an open heart and an open mind. So I'll just leave it at that. Thank you.
Thank you, Nick. I think the one comment I would have is, this is a Board of Health policy that normally comes in front of the Executive Committee about February of every year. And I don't disagree with the fact that Dr. Era is this board's only employee, but I think it's been, from what I can understand, historically, these policies all come in front of the board through the Executive Committee for commenting. If this isn't an area we're supposed to be in, then we shouldn't be seeing policies like this. Luke, have you got your hand up? Go ahead.
Yeah, thank you, Madam Chair. I'll just reinforce what you're saying. The Executive Committee reviewed this policy along with all the policies early this year. The board saw them a couple of meetings ago and adopted them all. So we just did a review and an adoption of these. What I would suggest, rather than debating the details of this policy, which was approved just a couple of months ago, bring it back. It'll come back around in early next year, and we can take my friend Ken's comments into consideration when we review it as an executive committee, or when the next executive committee reviews it. And we'll come back to the board with some recommendations and potentially changes or potentially not. But all we're considering today is a couple of minor tweaks suggested by staff to make this a little easier for them to implement. And I would suggest we just approve those changes and do the review in a few months' time. Thank you, Madam Chair.
Thank you. Helen Clare, did I see your hand up again?
Thank you, Madam Chair. Just exactly that what is in front of us today is to accept an existing policy. And if there is indeed a need to go back and talk about the value of specific gifts to Board of Health employees at particular timelines, that could be done by the executive. Absolutely. So I would be happy to move this for acceptance if that's necessary. Thank you.
Thank you. Dr. Era.
Yeah, thank you, Madam Chair. Just mention a couple of comments there, and I agree with everybody who spoke. Actually, everything there is not it's not mutually exclusive, but they work, all of them. I am the only employee of the board, and this policy is not for the employee of the board, rather recognition of all staff. It is constructed years ago, so the numbers but probably reflect years before. It was reviewed annually, or sometimes we skipped 1 year or so, but it was reviewed throughout. And it's not the only recognition that is offered to staff. Like Nick mentioned, and I've never seen Nick run out of words, but he said he ran out of words. There are many things that we do to appreciate our staff, and it is reflected in the strong commitment to the organization. Many people retired and during the pandemic came back to help. Many people were hired during the pandemic in temporary jobs and came back with permanent jobs. And there are around the year events and newspaper to recognize individual and group achievement of our staff. So again, I would agree the numbers are small. They were reviewed to be small a few years ago. Then we decided to keep them, if my memory serves me well, as so, because of the other things that we do. And whenever we look at these numbers, it's not the board would look at this, rather, and it's not the NIH would look at this. There is a team that's looking at this, HR team, there is a senior management team and management team to see these recognitions. And there is always the union. Anytime we're going to change something here, we have to communicate with the union to see how this affected. So again, the question at hand, like at the very end, rightly pointed, there was a practical sentence that would need clarity, or to change it to give clarity, to recognize people for the years of service they had. And if there is a need to look at these numbers, it can come to the executive committee and with certain recommendation from everybody around the table. So the table, I mean, the greater table in the organization, management, and HR, including the board, which we received the feedback today.
Thank you. Are there any other comments on this one? Seeing none, Helen Claire has moved this. Could I have a seconder, please? Beth, and all in favor? That is carried. Thank you. We have no other business, so now we will be moving in camera. So I need a mover and seconder to move in camera today to discuss two items. First is adoption of in-camera minutes from July 26th and July 31st, and then adoption of personal matters about an identifiable individual, including municipal or local board employees. The mover and a seconder to go in camera. Sue Patterson, Kevin Eccles. All in favor? That is carried. Thank you. We are back in open session. We only discussed those items that were listed on the in-camera session. And we have a motion to go ahead to nominate Nick Saunders and Bev Wilkins to participate in the interview process of the recruitment of the physician consultant. And Helen Claire, you had indicated you would move. Could I have a seconder, please? Chad? There's no further discussion. I will call the vote. All in favor? That is carried. One final item, adjournment of the meeting. Deb and Kevin, all in favor? We are adjourned. Thank you, everyone.